Good evening and welcome to the fourth It's a Pain public engagement event, which is entitled Pain Question Time. It's going to be chaired by Baroness Hilary Armstrong, and on our panel we also have Dr. Kate Bidwell, Dr. Robert Song, Mr. Ian Semmons and Dr. Joe Dunn. Pain Question Time is made up of questions which have been submitted by yourselves, and we have a mixture of questions from patients, from the public, from healthcare professionals and also from academic people. I personally have really been looking forward to this event for some time, and I guess that quite a few of you in the audience might as well be looking forward to this event too. I think it is going to be the highlight of this series. It's a Pain series is a collaboration between County Durham and Darlington NHS Foundation Trust and also Durham University. As probably a lot of you already know, my name is Joanna Quinlan, and I've been responsible for organising the lecture series from the NHS side, along with Nicola Massingham and also Dr. David Laird. And from the Durham University side, it's been Dr. Paul Chazot, who unfortunately at the moment is unwell, but he's starting to get better, so we wish him all the best in that. For those of you in the audience who are healthcare professionals, we have been approved one CPD point, so one continuous professional development point, from the Royal College of Anaesthetics, and we can produce certificates for any of those who would want one. If you can please state your name, your email and your postal address on the feedback sheet. So sorry, your email or your postal address, not necessarily both. And you can put that on the feedback sheet, then we will send you out a certificate. I'll pass you over to Baroness Hilary Armstrong, and I really hope you enjoy the lecture. Thank you.
Thanks very much, Joanna. My name's Hilary Armstrong. I think I'm here because I'm a trustee, a governor of the Foundation Trust. And, but before that, I was a local member of Parliament, and I've always been interested in the development of public services and the health service in this area and region. I am not an expert on the management of pain, so I'm not going to attempt to answer any of your questions, but I am here to learn from the perspective of as a board member of the trust, but also because I'm an interested citizen, and so you know, I was very I was really very pleased when Joanna asked me. I wasn't sure why, but as I say, board members have got responsibilities beyond attending board meetings and doing the internal stuff, and pain is such an important issue because some of it is clinical, but a lot of it is not, and there are ethical issues involved, there are social issues involved, and it's an issue that is not just current here, it is an issue that is important around the world, and our panel reflects that. So what I'm going to do is ask each member of the panel to just introduce themselves and say a couple of things about what they are bringing to the event tonight, and then we'll go into questions. I think the questions are incredibly wide and comprehensive, but there may be one or two things that if we really get through them, you feel haven't been addressed, and if we have time, I will then give you the opportunity to come in on those. But we'll just have to see how we go, because I don't want them to not reply fully to each question, and you know, we'll see how the evening goes. But thank you all for coming. Really good to have this sort of recognition of the importance of the issue and how we tackle it together And I know that there have been other events this week which are really about that. How do we actually get hold of the issue and make sure that we work on it in a way that really responds to the needs of people locally, in a way that they can identify with and they can feel they have some ownership of too. Right, Kate is first, and Kate is a GP in Durham side, so you know I used to be very interested and committed to what she was doing because she was in the constituency. Kate, if you can just start.
Good evening, everybody. Can you hear me all right on this? Thank you. Yeah, my name's Kate Bidwell. I've been a GP now for 27 years, most of that in County Durham, although I started out in South Shields. I've always been interested in why people get ill, more than perhaps the fact that they get ill and fixing them. And that led me in 2004 to start work with the pain clinic, when we started up an early intervention pain clinic that was run out of Shotley Bridge Hospital. Because I am interested in other things as well, and in trying to not just look after the patient who's sat in front of me, but to look after the broader issues of health, I also got involved in the work of commissioning health. So 3 years ago I was a chair of our practice-based commissioning group, and that then evolved and we changed into clinical commissioning. So I am currently the chair of the North Durham Clinical Commissioning Group. The downside of picking that job up was that I then had to drop my pain work. So I am not currently actively involved in any pain work at all, but I am very much involved in commissioning of health services.
Great. And next we have Robert Song, who is actually from the university and the theology department.
Yes, thank you. Robert Song, as Hilary said, I teach Christian ethics in the Department of Theology and Religion here. I'm not really a specialist in pain, either from a lay point of view, a patient's point of view, or a medical point of view. I do have an interest in medical ethics, more broadly bioethics, and the kind of areas I'm looking at in general at the moment are things to do with posthumanism. Posthumanism is the effort to technologically transform our bodies so that they can be superior to what they are now. And amongst the desires of posthumanism is in fact the desire to get rid of all pain and suffering altogether. And it's that kind of idea which I'm looking at. So I won't be coming at from a very local organisational or practical point of view, but I will be bringing a sort of broader perspective to it.
And then we have Joe Dunn, who brings a bit more of an international perspective.
Hi, I'm Dr. Joe Dunn. I'm currently working as a locum palliative medicine consultant based at UCH in Camden and Islington and community teams down in London. I've been in palliative medicine for about 7 years now, and as part of my training I actually spent 2 years working in Uganda, helping to develop some of the palliative care services there, and developing a BSc in palliative care for some of the nurses and clinical officers to help to provide palliative care on the ground, as there is a lack of doctors in Uganda. So we were involved in training some of the palliative care nurses in actually prescribing opioids to increase the access to pain medications in Uganda, and I'll talk more about that later.
And then we have Ian at the end, who is chair of Action on Pain, so really brings the patient's perspective.
Yes, good evening. I have to say I'm chairman of the national charity Action on Pain, which is a voluntary organisation that's been going for 15 years now, and we've developed into the major pain charity in the UK and further afield. What I bring tonight is a lot of experience in terms of helping people with chronic pain, helping to develop services. But perhaps most of all, I've lived with chronic pain myself for 23 years, so I have a bit of a track record there.
Thank you. So now you know who the panel are, And now I'm going to read the question that we're going to take them. I don't know whether have you got copies of the questions? No. Okay. The first question is from Diane Benzie. Is she here? Yes, Diane, right. And very straightforwardly, what types of pain are there? Are they grouped differently with a varying approach to treatment? I think that's you, Kate, to start.
Yeah, in theory, that should be quite a straightforward question to answer. And there is a simple answer and then there's a more complicated answer. Pain, for me, is one of the definitions is an unpleasant sensory or emotional experience with or without tissue damage. That is a simple answer. For me, pain is much more than that, because you've got the physical aspects of pain, you've got the emotional aspects of pain. There's a difference between acute pain, where you almost certainly have damage and it will get better, versus chronic pain, all of which is associated with changes in the emotions and changes in how people think. And you've also got differences between the sort of pain that comes from your musculoskeletal system, so your nerves, your muscles and your tendons and your bones, but also what we call neuropathic pain, which is pain that comes from your nerves. And different sorts of pain give you different qualities of pain. We try and work out from those qualities of the pain what type of pain it might be, and therefore what sort of pain relief might be the most effective for it. But I would very much respond that pain is, for me, is not a simple matter of here is a pain and therefore there is a pain relief there is a tablet to solve it. Joe, do you want to add to that?
Joe, you clearly have something to say on this.
Just when we talk about pain, particularly in palliative care, we often talk about what Dame Cicely Saunders, who's the founder of the modern hospice movement, talked about is the concept of total pain. So we're looking at the physical side of the pain, but also the social, the psychological, and the spiritual aspects of the pain, and these all impact on someone's pain. So when we're managing someone's pain, it's obviously the medications, the physical causes, but it's thinking about all aspects of the pain to manage them.
Anyway, Diane, do you want to come back on that?
No, I'm quite happy with the answers that's been provided, and I think from my own personal experience, I think it's not just something that, as Dr. Bidwell has explained, that can be expertise in tablets, painkillers, or using TENS machines and things. What I have a better appreciation of, I think, is the psychological aspect of it, that it's not something that's a quick fix or is a quick remedy to something. And from personal experience in my own family, that's something that's quite difficult to
deal with.
Yeah. Yes, thank you.
Okay. Okay, let us go on to the next question from Becky Thompson. Is Becky here? No, I'll still take the question though. How does someone's theological or philosophical view affect how they deal with pain and suffering? Is pain always a negative experience? I think, Robert, this comes to you.
Thank you. Becky being here, I've been very keen to know why she was interested in the question.
Indeed.
I certainly do think it makes a vast difference to how one experiences pain and how one handles pain. I think it's part of the modern world that we tend to see pain as something simply to be eliminated. Pain isn't something which talks to us. Pain is something which is mute. Pain is something which is just there. It is painful. We're unable to make anything of it. Whereas I think plenty of religious and richly philosophical views can give us just different perspectives on it all. If, for example, you think that pain is there because you're carrying some of the burden of suffering in the universe. If you think that pain is there because it can help build up character, it doesn't always, it can at times. If you think that pain is there because somehow we can share in the sufferings of Christ, as some Christians think, then all of those are different ways in which one can develop a sense that pain isn't just brute, dead, inert there-ness. It is something which we can begin to weave into a meaningful existence. I think it's part of the inheritance of the modern West that we tend to think that because God is absolute, because we have a deist view of God, that God set up the world and was unable to be involved any further, we don't have any sense now, as generations gone by we've done, that God can be present in pain. And if you have that sense, then you will approach pain, I think, in a very different way than if you see pain as something that simply is there to be eliminated and to be got rid of. So I do think different views of the world will make a huge amount of difference to how you tackle pain and how one pain unmakes a world. And the question is, how do we remake the world? How can we compose a narrative? How can we make sense of it? I do think religious and philosophical views can help us do that.
Okay, I'm going to ask Ian to come in and comment on that.
Excuse me, I'd like to concentrate on the second part of the question is pain always a negative experience? It certainly isn't, because pain actually can build up your inner strength. There's a challenge ahead, and living with that pain, the challenge is to move forward. That pain can drive you forward, because you can get stuck in a rut, and you have this pain and you think, well, is this going to be with me for the rest of my life? Yes, it probably is, but I've got to do something about it, so it actually drives you forward in quite a considerable way. But there's another side too, which we in the charity have developed something, and I know this isn't on camera, but I'm going to use a 3-letter word. We have developed something that is now used quite extensively, called solid days. Now, what is a solid day? Solid day is something where you go out and you do something and you have one heck of a time and it hurts, but you've enjoyed yourself. Now, that's really boosted you up in some ways. Yes, you might be grounded for a few days afterwards, but look at it in this way. For example, I went up in a microlized aircraft some years ago, and it was wonderful, but with a broken back, the vibration of the engine at the back was not very good, and I was grounded for about 10 days afterwards. That's a few years ago. But I have down days with chronic pain. But I pull out the photographs that I took up there, and it picks you up. So it's a positive way of moving forward. So yes, pain can be positive. Certainly can.
Okay. Anybody in the audience who want to comment or say anything about that? Yes. And can you tell us?
As a former patient with pain management program, that the solid pain was actually talked of us as worthy pain.
Right.
So that's a way to look at it.
Mm-hmm. Thank you. There was a nurse from the UHMD. Is she here? I'm assuming it's a she. That's a real bad thing for me to do. I'm sorry. Is the nurse from UHMD here? No? We're going to do this one very quickly because I think this one's a real techie one. Pain score. Is it an adequate tool? Is pain really what the person says it is? Go on, Kate.
Can I jump in that one? Because I really feel absolutely passionately about the second half of that question. Is pain really what the person says it is? Yes, absolutely. Pain is what the individual feels. It is not for anybody else to say what they think somebody else's pain is. And the pain score, I presume they're referring to the score of we constantly ask patients to score their pain on a score of 0 to 10, where 10's the worst pain you can possibly imagine and 0 is no pain. Is it an adequate tool? It depends what you're doing with it. If you want to measure somebody's pain after an operation, it might be, if you want to see whether what you just gave them is making them feel better. Is it a useful tool for chronic pain? I think probably not. And for me, much more useful assessments of chronic pain is around so how can you function with your pain rather than actually what is the intensity of your pain. It's, are you managing to do more things now than you were doing before?
Okay, I was at a hospital board trust board meeting this morning, and as I was leaving, the chief nursing officer said to me, don't forget, pain is absolutely and only about how the person suffering it feels. So, you know, he was giving me a very clear message this morning. Now we want to move on to patient-focused questions, and the first one is from Frederic Folazan. Great. I'm always pleased when you're here. What are the pain criteria for referral from a GP to a pain management unit? As in, how much pain, what kind of pain do you need to present with for the NHS to take you seriously? This is a very serious question, which of course was covered very extensively in the Francis report. So I don't know quite who's going to start. Joe? Or Kate? Which of you? One of you.
Again.
I think. One of the medics, anyway.
So you won't hear just from me this evening, I'm sure. It is a really difficult question. Again, it's not straightforward. Pain is a challenging condition to deal with, and particularly chronic pain. Chronic pain is something that we don't have a very good understanding of. We move from, both as clinicians, as patients, from seeking a cure and looking for somebody to make it better, whether that's the doctor or the patient wanting the doctor to make it better, often into a really, a period of real frustration if it's not getting better. And us starting to think, well, you know, it's the patient's fault they're not getting better, it's the doctor's fault I'm not getting better. And so the whole thing becomes quite difficult to manage. We're very fortunate in Durham that we have an early intervention chronic pain clinic, and that takes patients from 3 months of chronic pain. That's much earlier than there are services in a lot of other areas. But sometimes it's about having that discussion and being able to negotiate with the GP about, you know, okay, we've tried lots of things to try and fix this, now we need to look at another method. And looking at pain clinic services not as, well, that's the last resort, that's where you go when nobody can fix you, but actually using it much earlier on in your pain journey in order to try and help you to manage pain, even if that pain may well get better at some point in the future.
Anyone else want to say anything on this? Yeah? Okay.
I think the point about taking pain seriously is one that we're challenged with regularly in the charity on our helpline, where the person is not believed, is told it's in their head. And the situation there is, I think it's fair to say that amongst healthcare professionals in their pre-registration training, pain management is a very small part of that training. So I think a lot of the problem with being taken seriously is a lack of understanding within healthcare professionals where you first present. Quite often you'll say, for example, have an orthopaedic issue, and they will concentrate on the orthopaedic issue and not on the pain side of things. So it presents a problem as to how can you persuade that healthcare professional to understand that your pain is actually what you say it is, to take it seriously. You look at people, you can't see pain, which is a problem. And I think it's a question of education of healthcare professionals to have a better understanding of the impact of pain and how to push people into the right area to be treated.
Yeah. Frederick, did you want to say anything about that?
No, it's fine. I mean, I asked because I have a partner who suffers from pain, which he manages with medication most of the time, but he does have episodes which can last up to a week where the pain is more than what is managed just by the drugs. And I guess from his point of view, he believes that because the GP's already given him drugs, if he goes back to the GP, he's just going to be said, well, we've already given you that, just, you know. He doesn't believe that it's going to be offered any alternative, or that it's going to be believed beyond what he's already been treated for.
Okay, that's an interesting question that we may well come back to. I'm going to move on to the next one. Is Dr. Arigami here? I might not move on to it. Does anybody know about the tests for DLA? The evaluation of DLA. You know a little bit about it, do you? Right, okay, Kate, and then Ian. Ian, do you want to start on this one? Let me read the question first. Pain can be constant some days and weeks, but at other times, good days, it is manageable. How is this assessed within the evaluation of disability living allowance tests? The assessment tests for DLA do not seem to consider the impact of variable pain management. Ian.
Mine has been buzzing for weeks on this one. We'll continue to, I suspect, for quite a long time. There's a lot of uncertainty out there with regards to disability living allowance and its transfer to PIP, etc., which is now starting for test areas, primarily in the north of England. The problem with the system at the moment is that it is far too rigid. It's a tick box situation, and in terms of dealing with chronic pain, pain is very much an individual thing. We've been talking to the Department of Work and Pensions for some considerable time to encourage them to change the format, and there has been some changes. The problem is that when you go in for your assessment, they only see you as you are on that day. And also, what we found is the person going in for that assessment is often too kind on themselves, and they don't look at the broader picture. So we encourage them to get as much information about their condition, so that when they go to the assessment, they've got the evidence to show that this is how their pain affects them, not just on that day, over a year period or something like that. How is that pain going to affect them in the future? I was speaking to a lass on the phone just this week whose condition has worsened, and she is actually in one of the test areas now for PRP, and she's really worried about losing the situation, because when you look at her, she looks fine. And she will go into the assessment, and the first impression, when I first met her, I met some time ago, first impression, you're fine. So it's persuading the people who are doing the assessment, persuading the non-medical staff, the Department of Work and Pensions, that you have a valid case. And basically what you need to do is to gather as much information as possible, really from healthcare professionals, from your family, from your friends, as to how that pain impacts on your daily life. They will deny it, the Department of Work and Pensions, but they are trying to cull out the number of people who get turned down. They won't appeal. Others will appeal, and it moves on, and it moves on, and it moves on. Your biggest problem, and there are a lot of people out there claiming DLA, who really aren't entitled to it. So it's actually trying to show that your case is genuine. It's an uphill task. A lot of effort needs to be put in, but you can get through. It's a tough system.
Kate, did you want to add anything?
Just a bit, and it's slightly tangential as well, because I agree with you that the test is a really, really blunt test. It's a test that's designed to deal with every single medical complaint that anybody might have, so therefore it's not specific at all. One of the things that we've had more recently is you may have heard that instead of sick notes, we're now supposed to provide people with fit notes. And fit notes allow us to sign somebody as fit for work, but with a whole load of caveats around it. Because we know that in theory, if you have some form of employment or you have something that you find useful, a purpose, that you are likely to get better quicker. The difficulty is the theory of that and the practicalities of what you can actually do don't match up. So if you're fit enough to work 3 days one week, but only 2 days the next week, or maybe even half a day the next week, you're not going to hold down a job. And that just doesn't fit with the way the system works at the moment.
Yeah, I would say, the only thing I would say about what you said, Ian, is the evidence out there isn't actually that there are a lot of people out there claiming disability allowance who should not be getting it. Because, what is it, something like 50% of those who are turned down are then appealing and having their appeal. You know, I know it's going down now because they've reassessed what they're asking, but certainly at the beginning of the new system, it was at about 50%.
I think that's just for incapacity benefit to ESA at the moment, because the DLA tests have only just started.
Yeah, well, yeah. And of course, we have the history in this region that people were put onto incapacity benefit and so on in order to make unemployment figures look lower. But that is very historical, and I'm not going to get into that tonight. Not the right time to do it. Okay, I'm going to move on to, partly because I think it's a really important question, Brendan Hodgson. Is Brendan here? Brendan, your question, as far as I'm concerned, is really about how patient groups can help themselves and what is there out there for pain. But let me read your question. Most people have heard of organisations like Guide Dogs for the Blind, the British Heart Society, Cancer Research UK, the Stroke Association or Macmillan Nurses, even if, like me, they don't know too much about them until they may need their help. These organisations seem to aim both to fund research into a particular disease condition and to offer practical help and advice. What is the equivalent for pain sufferers? Is pain too diverse a topic? There is, for example, the Fibromyalgia Associations UK for that specific group, but some people do not seem to fit into an easy category. I think this is one for the Association of Pain. The
yes,
action on pain.
Brendan, there certainly is an organisation that does cover pain. We handle all types of pain. Our helpline is a real mishmash. You don't know when the phone goes, what you're going to be dealing with. We've taken about 59,000 calls over the years. So we do a fair bit. We liaise with other charities, with professional groups as well, to try and develop pain services, to give pain a better voice in the healthcare community and certainly within government as well. So we do an awful lot in there. To give you an idea, we've just finished a major project in Scotland for the impact of chronic pain in irritable bowel syndrome. So they're the sort of things that we do.
Anybody else want to say anything? I mean, I think that this is really important because you do need a separate voice for patients, but also where they can really say, this is the sort of thing I want some research on, this is the sort of thing I want people to be asking questions on, and so on. And actually, the future of healthcare across the things that really matter. That's not to say that acute stuff doesn't matter, but if you think about long-term conditions, which are the real challenge to the health service, unless you get patients more involved in what is happening to them and what they can do about that, the health service will just never be able to deal with that. And so that sort of action is very important. And I think what you would probably be wanting to say is we need, if action on pain is going to be the organisation, we all need to know about it a bit more. Okay, Brent?
I mean, I did add a rather flippant thing. If I want to have a holiday visiting the South America, who can I turn to in order to deal with all the potential problems caused by disability? I know disability is not about the same as pain, but I mean, taking that forward, as we came in, we were given...
They didn't give me that bit from you.
As we came in, we were given details of a conference or whatever it was in London. I thought, how on earth could I get some, because it's mobility for me rather than just the pain. Who do you turn to for practical problems like that?
Yeah, interesting. That one of the booklets we produce is called Have Pain Will Travel.
Yeah, and my very good friend Tanny Gray Thompson has quite a few good and bad examples of all of that. Yes?
You might be interested to know Pain Association Scotland, which you'll be aware of. They've got an excellent website with lots of information available on it as well. Pain Concern, they also have lots of useful online information. People might also be interested, if they don't know about it, there's the Pain Policy Coalition, which is an umbrella organisation which includes politicians and patient groups working together to influence things at a political level.
Good, right. I hope they're all talking to each other, that's all.
Yeah, I mean, they have tried to get together through Pain UK, which again my colleague there will be aware of, which is attempting to forge a coalition across all the pain organisations. If people would like to go on the British Pain Society website, there is a patient section, and we do try and keep the list on there really up to date in terms of the organisations that we are aware of. And I think, as people have said, they cover just about every condition under the sun, which I think gives us some clue to the complexity of what we're dealing with.
Right. Okay, thank you. That was very useful information. I'm miles behind schedule, so I'm going to push on. Next, the next couple of questions are really about finance and culture, and the first is from Dr. Leslie Armitage. Right? With the current changes to the way that many healthcare services are being commissioned, do you think it is possible that the pain management services of the future may be provided by any qualified provider, or AQP, which could lead to a number of different practitioners delivering different aspects of the service? How important do you think it is for pain management services to be commissioned as multi or interdisciplinary teams? I have to confess that were I not here tonight, I would be voting on that in about an hour's time. Okay, who's going to take this up? The commissioner or the provider?
I think I better as a commissioner.
You better start, haven't you, Kate, as the commissioner?
Yeah. As the commissioner now, I still keep calling myself a potential commissioner, but from the 1st of April, we are the commissioners. The advantage we have in this area is that I do have a very strong interest in pain services and would be really making damn sure that we do get the right pain services here. That is not to say that there isn't the potential to change things, but that we understand how important a multidisciplinary team or an interdisciplinary team is, and how important integrating that team is. The only reason why we might choose to go out to tender on that contract would be if we were not getting what we felt patients in this area were requiring. And if that was the case, then depending on quite what goes through Parliament, we will probably have to go out to tender, and that would then be under the any qualified provider. But we would be extremely cognizant of the fact that those services have got to link into other services. We can't have a single individual who is a pain specialist then running a service without all the other additional parts, because pain is not about an individual problem, it's about the whole person with the pain.
We've all got to get better at knowing what we want as the end result, and then helping the commissioners define that and ask the providers who can deliver that. And if that means the hospital then has to cooperate with the voluntary sector, with some individual private practitioners, and put in a joint bid to the commissioners, as far as I'm concerned, that's the right way to do it. I don't think any one organisation is going to be able to deliver this. That's not a very popular thing to say, but I actually believe that. I just know too many small organisations that are great at contributing, some of them in very small ways, to actually helping in different areas. And you know, none of us should be so arrogant that we say we know we can do it all. I sometimes think we can't. And sometimes we get into ideological discussions rather than saying what is actually going to work best for that patient out there. And in Durham we have a hugely scattered population, some of whom live a long way away from anybody else. And to think that, you know, the hospital trust is going to be able to keep an eye on the old lady at the top of the fell in Iceburn is a bit of a problem for me sometimes, and I want to make sure somebody's keeping an eye on her. I don't know whether that helps you. Do you want to come back on that?
Yeah, it's reassuring to hear what Kate said, and the fact that we obviously feel that an interdisciplinary team is what's needed, and we feel that the patients benefit from that. I'd be curious to know what other services, these kind of small services, you're thinking of, who those organisations are, who might be our partners of the future. I don't know whether you've got any specifics that you can share.
I keep giving them in to the commercial director to try and get us a bit more confident about putting our arms around people and thinking about people. I mean, in other areas, things like the lead provider is now having... I do a lot of work in the region on homelessness and people with addictions and so on. I chair one of the major charities in the region. And we do work that, quite honestly, the NHS just can't do with those people. And I'm not, I particularly picked something that isn't about pain, because I don't want to look as if I'm pitching for services or for commission products. But we now work with the lead provider to actually make sure we can get the service for the person with a severe addiction, how you get them into a job, all of that sort of stuff. The hospital can't do that, but actually you need all of that in order to help stabilise them. And their medical condition is only ever going to be addressed if you address those other things as well. And it's that sort of thing that I'm meaning. Sorry, I'm not supposed to be saying anything here. I'm just supposed to be introducing things. I'm sorry. Now then, is Leslie Bailey here? Sorry. Yeah, sorry.
I contribute to add to that. It's not this trust, but we're involved. I'm Northern Integrative Health, which is actually a private provider who's working alongside UHND to assist with the pain management service to good effect, I think, David, is that? Yeah. And that's and working very much from the interdisciplinary point of view and mirroring the NHS service exactly as you want it to be. Yeah. We're working on a project on wellbeing in Northumberland with the Art Gardens and the Duchess up there. And she's a very passionate person. She's bringing well-being together. And we're delivering a service out there in a few weeks' time where we've got the NHS giving talks on breaks and falls, and we're talking about pain, and we're talking about services that can be available. And in my mad mind, I'm thinking, well, I wonder if I can get the patient transport service involved to reach the elderly out in the rural areas. They're calling it the elderberries. I thought it was quite sweet. And they're trying to bring all those services and meshing it all together. And I think that's how I perceive and see the different services coming together to provide a whole provision.
Okay, yeah. It's all challenging. Yes. Is Leslie Bailey here?
Yes.
Right, Leslie. Leslie's question is, how does the experience of pain vary between cultures, if at all? And do different cultures' way of coping with their pain give us any insight in how we could manage our own? Joe, I think this is meant for you.
I think I would probably start by saying, actually, I think there is some variability between cultures, but I think it's very difficult to define cultures per se and say that this person is in this culture, therefore they experience pain this way, this person is part of this culture, therefore they experience pain this way. So I think pain does vary, as we were saying, between individuals. I think it's very difficult to say that it's down to cultures, but I certainly experienced, when I was doing the work in Uganda, people experience pain in very different ways, and their ways of coping with pain can be very different, because partly to do with their ways of coping with everything generally in life, really. There's a very interesting study that has been done comparing palliative care between patients in Scotland and between patients in Kenya, and looking at the different aspects which were important to them. And what they found was actually the patients in Kenya had a very lots and lots of support spiritually and from their families and from sort of local support, which helped them to deal with things, whereas the patients in Scotland had the physical things, they had all the medications they needed, but didn't necessarily have the family support, the spiritual support, the same belief system that the patients in Kenya had to help them to deal with what they were going through. So I think that's one of the sort of cultural differences. And I think it's something we can definitely learn from other cultures, is actually the importance of that wider network of people for coping with the difficulties that people are going through, even if we have a lot of the medications and physical needs are met, but actually it's the other wider needs that are not maybe met as well.
Did you want to say something, Robert?
Not really about the cross-cultural thing, which Joe's much better qualified to speak about than myself, but just more reflection on our own culture, which is that one of the reasons I suspect why we don't really attend to pain is precisely because pain is subjective. Because it's subjective, we therefore tend to think it's not really real. Because we can't quantify it in a very adequate kind of way, because we can't give it that kind of objective, evidence-based grounding, because we can't give it that kind of external target-related quality, we therefore discount it. And I think one of the dangers in our own culture is that anything we can't cure, we tend to marginalise.
Yeah.
It seems to me that we'd be much better understanding our relationships as clinicians and as patients in terms of care, and putting cure within the context of care. Whereas what we tend to do is to say cure, and if you can't cure, then marginalise. And I think that's often exactly what happens in things like pain, or in other incurable areas, on things of mental health, disability, palliative care, geriatrics, areas which just we can't do very much with because they're chronic and they're always going to be with us. And I think our medical system is far too oriented to a kind of technological curing it culture rather than a caring for culture. And if we have that, I think we begin to address some questions that we're talking about.
Thank you. Anybody want to come back on that? No? Yes?
I'm just curious to know, culturally, when you look at the cultures, the ones you mentioned, Kate mentioned a couple of different types of pain, musculoskeletal and neuropathic pain, but there's also a whole load of pain syndromes which have a big psychological component, like fibromyalgia and ME, chronic fatigue, IBS. When you look at other cultures, do they have the same prevalence of those kind of pain syndromes as our own culture? Or because they have a very different kind of psychological way of thinking about things and coping with things, do they have a different pattern of pain syndromes?
I don't have any of the facts and figures about it all, but my experience, I guess, a lot of the patients that I was seeing, a lot of them had pain due to cancers, due to HIV. There were patients with things like diabetes, with chronic pain from diabetes. The patients that I was encountering I didn't meet anyone with anything like ME with fibromyalgia. But it's difficult to know if they were out there in the community and having different remedies and weren't actually coming to the attention of doctors. So I don't know all the facts and figures, but they weren't presenting to the medical services.
Yes, sure, yeah.
I did have a question, but it really it's not appropriate to the level of pain discussion I'm hearing, I think. But I have tried any number. I'm an 81-year-old diabetic. We have been for 45 years. And I've led an active sporting life. I'm now taking codeine and proprietary things like this. But my question really for the panel was, the one that I haven't tried is acupuncture, and on the cultural scene, I thought I'd take the advantage, in case it didn't come up later, of asking whether acupuncture is considered a serious counter to serious pain.
We got anybody who's involved in complementary therapies? There are people in the audience, I know.
I have, yeah.
I mean, we have as part of our team, we have 2 physiotherapists where I'm working at the moment, and they've both recently done acupuncture training. There is a lot of research about using acupuncture for pain management, and I think there's a lot of evidence that actually it is beneficial. So I think it should be part of that holistic package, and when you're managing pain, it's considering all the different options. So we're obviously considering the medications, but it's not just about medication pain control. So there are other therapies that we need to consider.
Yeah. Okay. We got another couple of questions on the cross-cultural and the ethics, and I'll just move into those. Do you think that everybody, this is from Helen Liddell, is she here? Yes? A colleague of mine is same name. Do you think that everybody should have equal access to pain services regardless of where they live, are young or old, male or female, rich or poor, and so on? Who wants to say something? Yeah.
I guess on an ideal level, yes, in reality, I think when you look at the health services in other countries, it is extremely difficult to give that access to pain management. We struggle in this country to give access to people in pain management. It's an uphill task. It may be done in our lifetime, but I'd rather suspect not.
There's a lot of difference between should and reality. Robert, yeah.
This is not directly related to your question, but I do think one book that anyone who's involved in commissioning or thinking about healthcare should think about is the book by Richard Wilkinson and Kate Bidwell called The Spirit Level.
Yeah.
And what they argue very strongly, it's a very powerful argument, is that health outcomes are strongly related not to the absolute level of wealth in a country, that is how rich a country is, but to how equal that country is.
Yeah.
And I think they show case after case in all sorts of areas, not just medically, but right across a whole range of social indicators, that if you live in a country which is more equal, on average, people will do much better than if you live in a country which is wealthier. And that's a really, really important, I think, outcome. It redirects the whole political debate from the micro questions, which are important, of course they are, the micro-allocation questions, but to the bigger questions about the nature of the society we live in. And I do think that has important ramifications, and I can't believe it wouldn't have impacts here in thinking about pain as well.
Thank you, Robert. Can we move on to Satomi Miwa? Is she here? Yes. What are the care systems available for terminally ill patients and or elderly people who are in pain in Africa or other developing countries? Is it less prioritised than children's education, fighting against infectious diseases and so on? If so, is there anything that developing countries can do about this? And as one who works on ageing, I often feel that the elderly population are often an overlooked group, but they are the people we need to respect and care for. If you want to start on this, Jo.
So I think to start with, it's very variable as to what services are available for pain and for patients who are terminally ill and for elderly care patients. There are some very, very good projects that are going on across the developing or across the resource-limited setting. I have some experience most of my experience is in Uganda, but I've also some experience from India as well. In Uganda, one of the most important things in developing the palliative care service there was working with the government to get the changes made at the government level. So there is now, as I was talking about earlier, there are nurses, so they had a change in regulations as to who could prescribe opiate medications to enable pain control. And so the nurses, after doing some training, can now actually prescribe opiate medications because there are not enough doctors available to actually prescribe to provide the healthcare and provide these services. But actually it's also about changes in policy to improve opioid availability, so getting the medications into the country, changing attitudes. And again, it's something that Uganda has worked with the government and has lots and lots of support. So palliative care is now part of the national health policy in Uganda, which is not the case in a lot of developed countries and is not the case across the board. But it's working with the government, so it's having somebody on board from the government. But it's variable. There are, so in India, they did have lots of opioid medications available, and then the policies changed and the opioid prescribing went down. So people were then afraid when they prescribed opiates that they would get into trouble. So the opioid prescribing then changed. So it's so much of it, there's so many different factors involved. So it's about changing policy, about education of people. But there are lots of services available, but it's in no way comparable to in the UK at the moment.
Did you want to come back on that?
That's fine.
No? Okay. Okay. Jasmine, Sue. Is Jasmine here? She just has a really interesting question. To what extent should we be responsible for providing pain relief to developing countries, and how important is this compared to providing food and clean water? This is an ethical question, I think, Robert.
Gosh. One I was hoping to duck. Sometimes people talk in terms of the pyramid of needs, and that there are certain basic bodily needs that we need before we need anything else to get going. And clearly at the bottom of those would be straightforward needs for water and for food. However, having said that, those who live with pain would certainly be the best qualified to talk on this. But it does seem to me that we would be well advised to think in terms of pain as being very high up that list of things that we should take care of. And the reason again is that the reason we don't is because we think it's subjective and therefore doesn't really exist. And somehow learning to attend to the reality of people's experience and crediting people's experience is an important part of that process. And that actually validates their identity, that says actually what you're experiencing does count and is real. And so I think should be well up there.
There's a fundamental challenge in the question to how aid is given. And actually, my view is it shouldn't be us that decides the priority in Uganda or India or Bangladesh or wherever. It should be the country involved and the people living in that country, and we should be working with them on how you deliver those priorities. That is incredibly controversial at the moment, however, so I'm not going to go any further into that, but you know, it is the sort of issue that folk like me are dealing with daily. Right, now then, we're about, you know, we said we would finish around about now, so I'm going to take at least one other question, maybe two, but one in particular from Jill Castellanos. Is Jill here?
It actually wasn't from me. I belong to a support group called the Friendship Group, and we've all been through peer management program.
Right.
And so I actually invited the members
Brilliant.
to submit a question, and that was one of the questions that
Right.
the members submitted.
Great. So I think I've got two questions from you then. The first one is, if each member of the panel had one tip for managing pain, what would it be?
Since I'm at this end of the table, I'll start and then leave you with the more difficult answers. This was one that I wrote down something, and then I wrote down something else, and then I wrote down something else, because there are lots and lots of things that you can do about it. But for me, I think the most important thing is to try and understand your own pain as well as you possibly can, because the more you understand it, the more you can help other people to understand it, and the more you can understand what you can and can't do with it and how to work with it. So it's about really, if you like, paying attention to your pain, and that's something we don't do very well. We just spend most of our time trying to ignore it, I think. So really, really getting to grips with what your pain is all about.
Okay, anybody else want to have a go? Ian, yeah, you had?
I think basically living with chronic pain is a challenge, and facing up to that challenge in a positive way. Exclude the words can't do from your vocabulary. Have a sense of humour. Take one step at a time, set yourself realistic goals, and get your family and friends involved. Talk about the pain. And as I say, set yourself those goals which you can achieve. Achieve with the first one, do an easy one, because when you do it, it builds you up. But stay positive, but talk about the pain, don't keep it to yourself.
Right. Joe?
I think I've got two bits. So I think any sort of pain needs a proper full assessment as to what the underlying cause of the pain is, because it's very difficult to treat pain unless you know actually what's causing it. But I think it's essential to have a holistic approach to management. So it's not just about we can prescribe you these medications, it's actually looking about what other things we can offer. So tackling all the physical side, but the social, the psychological, the spiritual aspects of that pain, and addressing all of those different aspects, which is why you need a multidisciplinary approach to pain management.
I'm not sure it's fair to ask you, Robbie, you're like me, you know, but if you want to say something, please do.
I think we are relational beings. We're creatures that live in relationship. And one thing about pain is that it isolates us, it individualizes us, it keeps us away from other people. And it does seem to me that it is not only the case that we will experience our pain, but those we love will also experience our pain. And I do think probably the most important thing is that we are kind to those who are kind to us, that we actually learn to love those who love us, that we attend to those who attend to us, that we care for those who care for us. So I think that'd be my sort of top tip. I can't help saying, I'm a Christian theologian, and I can't stop saying that pain can be all-engrossing, but that there is a reality beyond that pain, and that a reality did actually come and share our pain on the cross. And I'm saying that obviously as a Christian theologian, but I do think this gives some insight into how one can begin to handle it.
Thank you. Now, I'm really sorry because I have missed out 2 or 3 questions, but I was asked to finish at about 8:10, and we've just gone over that. If any of you who didn't get your questions answered want to come and have a quick word with whoever you think is the person on the panel that would have been answering your question, please come down and ask them. I haven't asked them about that, but you know, I'm sure they will have a quick word. I just want to say thank you to all of you, that all of you are here for reasons I suspect either about your work or the pain that you yourself have had and your experience of services. I hope that you're going away with the recognition that you are as involved as a patient, if you're a patient, in the solutions as any of us at this end are, but that it's only when we all work together and pool our knowledge, experience and understanding and work for the right outcomes that we'll actually begin to really shift the understanding and the work around pain. There are no easy answers in this. It seems to me there are virtually no easy answers in healthcare these days. But, you know, I know that it's an issue that certainly the professional colleagues here from the Trust take very seriously, but that so do other people involved in working with them on actually tackling this and tackling how we address pain in this area. And I'm really feel that I've been privileged to hear from you, but also from the panel about the whole of the different aspects of this that come together. So thank you for coming. I understand there are other meetings in this sort of series, not about pain. I don't know whether you want to say anything about them, Joanne, or just say they're on the website or something.
Come down from here. This is our 4th event, so we've got a lot of your details, so when we run further events we will let you know and send out some information via email, so just bear with us.
As I say, thank you for coming. We are all working out how we more effectively get patient-centred services. And that's part of what this discussion and debate is all about. So thank you for coming, and thank you to the panel.